Welcome, everyone. We are happy to have you all here. Hannah and I will be presenting on the topic of long COVID, patients researching themselves and advocating to counter false information and disinformation with data. I'm Gina Asaf. I'm in DC. I'm a digital designer, researcher by trade, and I work in the global development space. I'm also a long hauler since March of 2020, and it's 2 years now. Hannah, do you want to introduce yourself?
Sure, yeah. Hey everyone, my name is Hannah W. I'm also a co-lead at Patient-Led Research Collaborative. We're a group of long COVID patients, and we call ourselves long haulers. It's a patient-coined term. And before the pandemic, I was a computer scientist and a qualitative researcher. And after when the pandemic hit and I discovered that I haven't recovered, I transitioned my focus to helping to do research at Patient-Led Research Collaborative and helping the organization grow.
Yeah, and we are from Patient-Led Research Collaborative, as Hannah mentioned. And we are a group of long haulers who are basically researching and studying ourselves. We are all long COVID patients. We're majority, I think all of us are still sick to some degree. We were formed in April of 2020 in the Body Politics Support Group in the data channel. We are 45 plus patient researchers across 3 continents. 5 of us are co-leads, you get the ones that are on the screen here. So Hannah and I are presenting, but we have Lisa, Athena, Hannah Davis, and we all are 3 of us are in the US, and Hannah Way is in Canada, and Athena is in London. And we, so Hannah and I both have experience in the tech sector, working, as technologists and designers in design and participatory research, but the rest of us, we are very interdisciplinary. So we have backgrounds in medicine, participatory design, neuroscience, public policy, cog science, research, engineering, data science, psychiatry, pediatrics, social epidemiology. So we're very interdisciplinary, and I think it's part of our success is in that. And so we all got together, to understand what was happening with us, as the narrative was not in the media, and what we were hearing did not match our experiences. And we knew that we needed to understand ourselves and produce information to the world. And so we are going to talk about 5 common long COVID and COVID misinformation, disinformation. We're going to present our journey so you understand how we kind of arrived at some of this as patients and researchers as we were encountering this information. And it was disvalidating our experience. There are many more misinformation, disinformation, but we're focusing on these as examples. And we're going to discuss how we as patients and researchers battled them. So, the first one is, 14 days or 14 days it will take you 14 days to go through COVID and you will recover, or you are going to go to the ICU and either die or get better. And that's all we knew. That's all we heard. There was the narrative that 99.97% were going to recover. And the other one was, if you don't have a positive test, whether it's a PCR or antibody, there's no way you have COVID, and there's no way you have long COVID. The other one, which was a big one, which was it's a respiratory disease. So you should get a cough, chest stuff, maybe flu-like symptoms, but that's all. The last one, which we're still dealing with, I mean, actually all of them we are, is you're still sick, it's all in your head. So we're going to go through these and discuss how we, what data we presented, what data we saw, and how we went through it. But before we do that, I'm going to pass it back to Hannah to kind of present some questions and concepts to think about as you're as we're going through these. So Hannah.
So as Gina mentioned, thank you. We want to share a little bit of how we arrived at where we are and encountering these types of biases and narratives. And we want you to as you listen to our story and have discussions with us about this information, we want you to ask yourselves these following questions. Number one, who gets to produce data, curate, and influence with data? Number two, what format of data is widely accepted as evidence? And what does that say about us? And number three, what does long COVID misinformation apply about our own biases, society's biases around the idea of personal health and how that's being achieved? Next slide, please. We also have a couple of concepts that we find crop up time and time again when we do encounter disinformation. And I just want to go through, we'll be bringing these up during our discussions, but I just wanted to go through them and give you a description of how we interpret these themes. So first is ableism, that refers to bias, prejudice, and discrimination against people with disabilities. It hinges on this idea that people with disabilities are less valuable than non-disabled people. And this is directly related to this idea of healthism. It's the preoccupation with personal health as the primary focus for the definition and achievement of well-being, a goal which is to be attained primarily through the modification of lifestyles. Next slide, please. We also encounter themes such as doctor-patient divide, and this is not limited to doctor and patient, it's also doctor to researchers, patients to researchers, patients to any authoritative figure in the medical community. And this implies a dichotomy that separates the healer from the sick, and it prioritizes the medical voice over the patient voice, as opposed to encouraging collaboration and recognizing patients as co-producers of scientific knowledge. And hopefully, as you listen to our presentation, we'll have quite a few examples of that. The last but not least are accessibility blind spots. So the blind spot, assuming that people have free or easy access to testing, medical care, and current and all future access to care. Next slide, please.
Yeah.
So
I'll talk through this one. Yeah, Hannah. So the first one is going to be around the first misconception that we encountered, and you know, the points that Hannah made. Please keep them in mind, because at the end of each section, we're going to go over them and have some questions and have a discussion around them. So yeah, the first misconception is the recovery binary. There was a lot of misconceptions around that. This one was the first one we encountered as early COVID patients in 2020. And I believe to this day, there is still that misconception. You're going to get really sick and go to the ICU hospital, or recover easily in 14 days. That was a narrative that was prevalent, and still to this day, it's happening. So majority, if not all, health sources, including the WHO, the CDC, were presenting COVID as these outcomes as two binaries. Here's one piece we pulled from April of 2020, or March of 2020 from, this is from, the sources down there, one of the medical, I think Ohio State University, basically saying, generally a mild to moderate case will run its course in about 2 weeks. And you're going to have flu-like symptoms. And this, this is what we all assumed, right? But the reality set in. And, we all saw, those of us that got sick in March and April and early, that this was not the case. And we as patient advocates and patient researchers understood that this was a binary that we needed, this narrative that we needed to counter. So we all got together, and so let me talk to this one on the left first. So this article was kind of a big changer for a lot of us. Fiona Lowenstein, the founder of Body Politic, a support group that was created for long COVID patients, or COVID patients in general, when they realized that COVID was not matching what many people were expecting, and we needed support from each other. And we saw this article in the New York Times where this was discussed, and there's a link to join the support group. So
just to jump in, the date on this one is April 13, I believe, 2020, and that was just for some context, that was about 1 month into the pandemic in North America. So many of us were finding ourselves not recovering and panicking because of what we heard on the news of the disinformation about the two binaries. So having this this reporting surfaced around that time was very meaningful and very contextual to what we were experiencing.
Yeah.
Sorry, back to you.
Thanks. Yeah, and so many of us saw this article, we realized we were not alone, and we joined the support group. And this is how the research team found each other. And this is how, a lot of us realized, we were discussing our symptoms, we were discussing all these things that were happening to us that was not something that we were seeing in the media, by our medical staff that were telling us. They were surprised that we were still sick. They were surprised by some of the symptoms we were reporting. And so we decided to put together a survey, kind of looking into a lot of these questions that we all had that were not matching what we were seeing of data that was being produced by the media at the time and by our medical staff and folks that we were talking to. And so we put up all the questions that we had, and we, it was around recovery time, symptoms, testing, and much more. And we published this all in a first report that we put out, and the date here is May 2nd of 2020. And this we put out really, very early on. So I believe it was one of the first reports, on the topic of long COVID and the fact that there was a prolonged recovery time. This got a lot of attention, and this is where we were able to kind of give data and material to the media and give voice to patients and across the world going through a similar experience. Ed Yong, a pretty prominent science reporter, wrote about us in the summer of 2020, early summer. They saw our research and wrote a whole entire article about how it can last, and at that time, several months. Of course, now there's more media on this about it being a year later, we're still experiencing symptoms. A few years later, we're still experiencing symptoms, and there's still media on that. And on that narrative, and this is thanks to the advocacy that the patients did and the research that was put out that really put long COVID on the map. And as you can see on the right, here's an article that was put out on how and why patients made long COVID, published, and it goes into the history of how this was created by also a couple of long COVID patients. And despite the efforts, patients are still correcting the misinformation on the nature of recovery. As I said, this narrative is still stuck. This was material produced by the CDC on a flow chart discussing, the binary. Again, you're gonna either, get really sick, go to the hospital, and then maybe you'll recover, or you're gonna have critical care, but then you'll recover. And as you can see, there's not one mention of this longer recovery time. And as you see, Athena from our group is correcting this. This is a lot of what we're doing. We're advocating on social media, we're putting out data, we're correcting, publications from official health organizations. And here, somebody on the right from the long COVID community is saying how some of the narrative on long COVID early on has actually even put people in a mindset, to even when you're thinking about what research to do, makes it, kind of eliminates that from the options of what you're thinking about. And I'll pass it back to Hannah.
Thank you, Gina. Just to tack onto that last point, it's not efficient for patients to be countering these narratives back and forth and still tied directly to what we'll talk about with the prevalence and the Count Long COVID movement. The thing that we are advocating for now is to have patients at the table to define these policies in the first place so that we don't have to spend our unpaid time to correct them. Next slide, please. So the prevalence of the long COVID movement, we saw something very interesting while we were experiencing illness, prolonged illness, and not being heard. We saw that in 1.5 years since we started doing this work, we went from seeing 1 to 20 people experiencing lingering symptoms. That is recorded and publicized, to 1 to 10, and now 1 to 3. Now, this is very inconsistent and very weird. And you can see from the screenshots, the recent Reuters article estimates almost a third of people report lingering symptoms. And this was off of a large study done, I think it was in Denmark, a couple 100,000 people. And then the ONS from the UK has estimated 1.5 million people still living with long COVID. And this is 2.4% of the whole population. It's not just COVID patients, but the whole population. So it has gotten to the point where we have recognized that this is a very likely, disability is a very likely outcome from COVID. Now, why was this narrative buried? Next slide, please. Well, it goes back to what we talked about before about having it drilled into society that there is a binary in outcomes. You know, it's either you recover and go off on your merry way after 14 days, or you die, or you end up in the ICU and have a very hard time recovering. And there was no gradient in the middle to describe this bad outcome that includes people who become less healthy, less productive, and have more issues carrying on their everyday life. So this is an issue with surveillance. We don't have the tools or the infrastructure or even the awareness to have surveillance at the beginning of the pandemic. And this is a massive oversight, and it's largely due to disinformation. Next slide, please. We have seen attempts to make this data available. So other teams have tried to gather prevalence data, and there are quite a number of issues attached to that. That's also due to not understanding long COVID. One of the issues that we see quite prevalently is having patients report long COVID in an app. And we want to bring up this topic specifically because we know that quite a lot of you in the audience are in the tech world. So there are some issues that are particularly attached to this type of solution, because when you design an application or a digital platform to help people report their symptoms, you know, your gathering of prevalence or your the prevalence is then dependent on the opt-in process of data reporting. Now, only 2% of people kept reporting long COVID symptoms. And that's not to say that only 2% have long COVID symptoms. It's because, and we did this research survey throughout social media, because people stopped reporting in the app. And why did people stop reporting in the app? It's because the clusters of the COVID-19 symptoms discovered in this study was based on the acute phase of the illness, right? So there weren't any symptoms back then on fatigue, post-exertional malaise, common symptoms that long COVID patients experience. They were not recorded within the application. So there was no way for people to track them in the first place. So eventually people gave up talking about their symptoms, and it wasn't tracked. And this study was widely publicized, and this 2% was then taken at face value by medical professionals and hospitals and clinicians across the world as the de facto statistic for long COVID.
Yeah. And I'll add to that. I mean, I think this was a bad, you know, it was basically bad research methodology used. you can't use opt-in data for determining prevalence. And, and I think, that is just something you would not do. You have to do like a sweeping, almost like a household survey to get that kind of data. And we had noticed that, and we noticed that like this could cause a lot of harm in terms of policy. So we, discussed it.
Yeah.
I think I was doing this one, right, Hannah? Okay, so
Go for it.
The next big misinformation was around access and interpretation of COVID test results. So this impacted a lot of us early on, and up to this day, it's impacting us. So if you didn't have a test, that there's no way you had COVID if you didn't have a positive test and you didn't get access to medical care. And so many patients did not have access to PCR testing in the beginning, or did not get tested at the right time, because a lot of us were told to stay home, do not leave your house. Even if you're sick, you're going to get better in 2 weeks. So don't worry about it. You don't need a test. And here are some messages that we pulled out from our support group, where doctors were telling folks that were sick months later, you tested negative in March, and I'm not going to see you, but this person was still having symptoms. On the left, some person was saying that they wanted to get an antibody test because they weren't able to get the initial test, the PCR. The doctor was like, oh, I'm going to swab you for a PCR test, and this is way many weeks later, and now we know that. And I'll talk about that in our research, that you're not going to get a positive test. Timing is really is critical. And this led to disbelief, telling people it's all in your head, and we'll go into that topic as well. And so this was something that our group, in the survey, decided to ask this question, because we knew that there was some questions around, or we had hypothesis that the result was related to timing. And so we had asked the question in the survey, when did you get tested and what was the result of your test? And here you can see, that we found that those who tested negative tested later by an average of 6 days than those who tested positive. And this was significant results. And so we published this, and this was, there was a few studies out there that had mentioned this that we found later on, but we were one of the first to kind of discuss this issue about the sensitivity and how it impacts, our care and also the belief and how healthcare professionals were dealing with us. This was something that as well kind of impacted those who didn't have access to test because maybe their insurance wasn't great, or it was too far to go to a test. Until this day, we have this problem.
And this disproportionately impacts marginalized communities as well.
Yeah, for sure. And so now, in the beginning, it was only about the PCR, but then later on, for the long COVID community, they were telling us, okay, now antibody tests are there, so maybe you can get an antibody test, and and by the time we had access to an antibody test, it was 3-4 months later, for a lot of us. And not only that, we found, and there's a lot of research to prove this, that long COVID can actually be predicted by a weak or lacking antibody response. So you're more likely to not produce antibodies if you have long COVID. You'll have longer symptoms. And this, and where, you see the study on the left, and this article that said everyone is going to produce antibodies, and if you're seeing this as a medical professional, you are going to assume that, hey, all of these patients, no matter when, are going to get antibodies, and that's the narrative that was prevalent at that time, and until this day, even. And why was this important? Why are we caring about this? Of course, it's a false information, but it's also impacting our care. Many long COVID clinics were requiring positive COVID tests to access care. So these are some examples. University of Michigan, you must have a positive test. Scripps Hospital in San Diego, and these are big institutions that were requiring positive tests. But again, we were sharing data and advocating to say, long COVID clinics should not require positive tests from patients because, low levels of antibodies, here IgG, were predictors for post-COVID syndromes. And this is important. We were trying to put this information out because it was impacting our care. And thankfully, and due to ongoing long COVID advocacy and some of the data that people are putting out, the CDC published, clinical guidelines to account for the lack of test results. So you can see here, this is from the CDC saying it is possible that some patients with post-COVID conditions will not have had positive tests because of lack of testing or an inaccuracy. This was really significant. And you can see Hannah here is tweeting about it, talking about that and signifying how important this is. Unfortunately, this issue is still a problem. And actually those two clinics are ones that I still have those guidelines. So this is a continued effort by long COVID patients to advocate for our care. And this is impacting, a lot of people who, didn't have access to testing, and they are from, going to be from marginalized communities, but also like the early wave of COVID folks. But even with the Omicron wave, a lot of people didn't have access to testing. This is much later in the pandemic. So, this is a problem, and it's going to require continued advocacy by patients and battling this misinformation. So this is what one is around symptoms. And I think after this, we'll have, one more section, and then, we'll go into another discussion. So we don't know what we don't know. And here we're talking about the symptoms. So, early on, and again, in April 2020, health sources were mainly talking about respiratory symptoms and likening it to the flu. And that's what we all expected, right? But then, as we were comparing symptoms with each other and with, in the long COVID communities and also with other COVID patients in general, we knew this was not true. They were saying that maybe in May, the only other symptom that people talked about was the loss of taste and smell, but that was it. Otherwise, you're going to have like flu-like symptoms. And up till this day, I think this is a more recent article on the right. They're still likening it to the flu, and this is actually impacting decisions on opening schools and classrooms, which is definitely an issue. And so this one, if you're determining if you have COVID symptoms or not. It'll be confusing if maybe one of the people, Hannah Davis in our group, she was having trouble interpreting a text message, and she had extreme neurological symptoms early on. And she wasn't sure it was COVID until other things happened. And then she, was around other folks that, kind of discussed potentially that it was COVID. So this was definitely misinformation that was impacting us. And early on, this is where we felt the need to aggregate the symptoms that we all were having and comparing them and seeing, how many of us are getting what symptom. And on the left, this was the very early report we did in May of 2020, where we collected all this data on symptoms. And we found that, we were, people were, reporting a lot of other symptoms. And actually our latest that we released in 2020, preprint and then now published article reports over 200 patients reported 200 symptoms across 10 end organ categories. So we're not like, respiratory is there, but there's, gastro symptoms, there's neurological symptoms, there's many other symptoms that were not being discussed. And the data on this was coming very slowly. And so us reporting on this early on was actually battling a lot of the misinformation around this.
Just to jump in, it's quite interesting thinking back now. During the summer of 2020, we already had an inkling that neurological symptoms was going to be one of the dominant markers of long COVID. And we were actually talking to scientists who work with CDC and folks who are trying to monitor the situation. And, we already were talking about COVID being a neuroinvasive virus. However, that was not communicated to the public for at least another 4 or 5 months. And in fact, one of the previous slides where we shared the CDC clinical guidelines that was published, I think it was in November when Biden, coincidence, not really, when he became president, and that the long COVID initiatives got fast tracked. So there were definitely some political things going on in there that prevented good data and good information going out into the public.
Yep, exactly. Our report on the left-hand side, this one was one of the first, kind of reports talking about, at least, in our sphere of world, there might be in other countries where it was discussed or in other mediums, but the brain fog and the concentration challenges this was reported in May of 2020 when this was not discussed at all. I remember my brother, who's a MD, he was super surprised by these results. He was like, wow, these many people are getting brain fog and concentration challenges. That's not expected at all. And in some folks, it was more common than a cough. Which was, super interesting. And this was the reason why we had asked it was because we saw so many people in the support groups asking, like, are you having a trouble doing this? Is your brain feeling, like it's hijacked, that sort of stuff? So we're like, we need to put this in here to see how many people are experiencing that. And as Hannah said, we do think there are some political motivations of not talking about this as much, because of, some of the policies that were being made around, what to do with COVID and the pandemic in general. And so later on, we actually went into depth into this because we realized there's a lot more, and we broke it down by groups. Cognitive functioning, memory, speech and language, etc. There's a bunch, and we put prevalence on each one. So we went into a lot of depth. You can find our publication and see a lot on that. And there's a lot more data right now on this, thankfully. So yesterday, a couple of days ago, there was research that was put out there from the biobank in UK saying that people who get COVID, they compared people who got COVID who didn't get COVID, have big differences in the size of their brain, and there's cognitive decline. And so this is a huge finding, and it confirms what we were talking about early on. And as you can see in July, there's warnings of brain damage, but we were reporting on it early on, and patients were talking about this. And this is so important, why it is important to listen to patients that are experiencing these things when data is not out there, right? And I'll hand it back to Hannah to talk about this big concept, which is really important on psychologizing long COVID.
Thank you. I just see in the chat that Tuli mentioned about the situation in Finland, that the director of Finnish Institute of Health and Welfare even addressed that COVID has won. Long COVID prevalence is also minimized in media reports. Yes, it's quite common to see, myself, I live in Canada, it's quite common to see governments who don't have the capacity or the means to track prevalence just completely throw their hands up and give up even trying, which is terrible for health outcomes. So to lead into this next point, it's all in your head, psychologizing long COVID and its recovery process. Despite all the research that we have conducted and collaborated and seen on neurological symptoms and other physiological symptoms related to long COVID, we still have a huge pushback from folks in the medical community who try to frame long COVID as a psychological issue. And next slide, please. And one of the talking points here is to conflate long COVID with general pandemic anxiety. And this is very damaging, as you can imagine, to folks who are trying to seek care for their physiological problems. And these are two articles. One of them is an article. The other one is a journal publication that suggests that long COVID may be associated more with the belief in having been infected, as of implying people are pretending to be sick and pretending to not get better. And I want to tie this back into our definitions of healthism and ableism, and really question why folks would make these conclusions, faulty conclusions. Next slide, please. So patients like ourselves, we understand that we are harmed by attributing unexplained physical symptoms to psychological issues. So this article in Washington Journal is from one of the folks on our team who's a psychiatrist, and he wrote a rebuttal to this narrative to try to counter the misinformation. And the core of our advocacy around not psychologizing these symptoms is because we need actually more tools and more resources to help patients figure out what where their physiological symptoms may come from. So for example, if somebody shows up with a pulmonary issue, they need medical imaging, they need more testing, and not to be dismissed and say, oh, you just have general anxiety. And there are quite a number of motives behind this information. Next slide, please. And we think that a lot of it has to do with this misconception that you can recover by sheer willpower. And these, I'm sharing some very widespread tweets and articles that tout this narrative that, the fear of COVID and long COVID perpetuates people's illnesses. Or even it bleeds into the way that clinics run their recovery programs. So the example on the right here is from a physio institute that deal with pain tolerance. So let's come up with a plan so that long COVID patients can tolerate more and more pain because it's in your head that's stopping you from recovering. And these are very dangerous narratives to patients, because a lot of the causes or the perpetuating causes of our symptoms is due to things like post-exertional malaise. Next slide, please. So us patient researchers and collaborating with researchers who are in ME/CFS, which is another chronic illness, and HIV researchers collaborated to dig into this phenomenon of post-exertional malaise. And essentially what happens is when you exert yourself, you actually don't get stronger, you get weaker, your body breaks down, it flares up, it sets off an inflammatory response, and you may be bedridden for a few hours to a few days to weeks. And this condition called PEM is within our patient community and at a very high prevalence. When we did our 2020 study, we found over 70% of people reported post-exertional malaise. And this also ties directly back into why this is not widely known in marginalized communities, because this is a very chronic illness specific term, right? You won't check off in a box that says, I have post-exertional malaise if you don't know what it is. What patients do report is, I feel especially tired after a long workday, or I have trouble walking up the stairs when I never had this issue before. And these narratives are very, very easy to dismiss if you have a care provider who isn't educated on long COVID or know about post-exertional malaise. Next slide, please. So we want to go over a couple of things, especially for folks who are reading, keeping up with news and trying to figure out what, where this misinformation come from and how it spreads, especially pertaining to COVID and long COVID. So one of the things that these are practices that our team have established, and we try to advocate for others as well. So one of the things that we try to look for when it comes to a piece about COVID and long COVID is that there a broad range of experts, including people with lived experiences. It's not enough to just get a quote from a doctor and not have anybody who is actually impacted by the care and the policies and decisions not be heard throughout the piece. Does it also acknowledge accessibility issues such as testing, vaccine accessibility, hospitalization? A lot of people, as Jeff mentioned, they're not wanting to go to ER anymore, but still experiencing symptoms. And does it respect the views of disabled people and researchers? There's a movement called Nothing About Us Without Us. So you can search that hashtag on Twitter. And that movement talks directly around including patients at the table for any news policy, medical research. One of the other things that we, as the patient research team, also look for is the track record of this person's work, either the person who's writing the article or doing or leading the research. And if you do a little Google search, sometimes these are real examples that we pulled out. Some of the people who promise quite a lot around cures for long COVID, they actually have a history of selling miracle cures to other chronic illnesses. And this is why it's also important to connect with other communities who have been here for a long time, like the HIV, the MACFS community, because they know these people too. And we also see examples of economical influences, such as this person is helping hospitals cut costs by advising physicians on how and when to label patient care as low value, which means they might suggest things that are psychologizing a condition because it saves them money. We also have issues with promoting back to normal policies, as we've seen with this new wave of misinformation around children and going back to school and pertaining to children with long COVID. And this completely ignores the effects, the devastating effects of long COVID on children, especially unvaccinated children. We also look for issues around funding. So who funds the work and the research, and what are their incentives? And this is directly related to the person's track record as well. We see government programs promoting job creation, which by itself is a great thing. It's a great endeavor. However, the way that it's set up is to promote remote-friendly cognitive behavioral therapy, which translates in patient terms to talk people out of feeling sick. It's an ineffective solution. We also have government initiatives aiming to rush sick people back to work. And this is my biased framing, but this is basically what my own government in Canada are trying to motivate in clinics across Canada. They want to see people go back to work and contribute to the economy, but not fully understanding the the course of recovery for long COVID. And so 3 months is not nearly enough for a lot of patients in our community, especially when it comes to post-exertional malaise, pushing themselves to exert, to work, to take care of their families. And what we should be pushing for are social services that help people ease back into work, paid leave, and better access to medical care. Next slide, please. So this is the last slide. We also, as researchers, look into how soon was the study published and how soon was it being talked about in the news. And especially this is very contextual to the economy, to the pandemic. Sorry. Articles citing preprints have become a very common practice, and this by itself is a good thing. We want data to be shared fast. We want other teams to collaborate at a faster rate during the pandemic. However, studies that are rushed to press may contain bad data and inconclusive evidence, especially if they are published as a preprint. That doesn't mean that all preprints contain bad data. If you're in technology, think of preprints as a GitHub server where science papers are subjected to revisions and deletions. I know that from personal experience, when we published our preprint, it was Christmas and our team left to enjoy ourselves because we were just heads down work for the past month. And when we came back, we were met with couple of very interesting article headers that said COVID shrinks penis size, and they were citing our article, citing our preprints without ever talking to any of our team members. We were away, we were off. So that is a very likely pathway of misinformation to watch out for. The last one is there a selection bias within the research itself. As we mentioned in long COVID, we see biases in testing and antibody testing, hospitalization status. And whenever there is a cohort that claims to represent the majority of long COVID patients, but they require test results and hospitalization status, they in fact do not represent the majority of long COVID patients in our experiences. And that's something to watch out for. Something that we do advocate is to follow the WHO's case definition. And this is something that our team and other long COVID teams help to develop.
Yeah, and thanks everybody for staying a little extra over the time. I know we're like 10 minutes over, but so thank you, we appreciate it. And thank you for listening to our presentation. You have our contact information. We are patientledresearch.com and at patientled on Twitter. And here are some patient groups and allies that we work with and we are aligned with. So thank you so much, and we appreciate, thank you so much, appreciate it, appreciate the thank you, Tuli and everyone else, and have a good rest of your, Mozilla Festival sessions, and hope to, run into you all at some point, and and let us know if you have any other questions. I mean, we shared a little bit, there's so much in the past 2 years that we've had experience with, and so we're happy to answer any other questions later on if you want via email or Twitter or whatnot.
Yeah, thank you everybody for attending.
Yep. All right. I'm going to stop this and we will exit.